Thanks everyone for joining our AMPATH virtual fireside chat from, I know at least from Indiana, Toronto, Eldoret, and I suspect somewhere else in the world too, but I don't know where everyone's joining in from. So our fireside chat today is part of our IUPUI, the Indianapolis campus of IU's International Festival Week event. So we've got some people joining from our campus here as well that may not be sort of regular attendees of our AMPATH events. So for those of you who don't know me, I'm Adrian Gardner. I'm the executive director of the AMPATH Consortium and the director of the IU Center for Global Health. And I'm here in Indianapolis in the office. As many of you know, I was based in Eldoret, Kenya for the last 7 years or so, where we had our weekly fireside chats at IU House, which have provided a real space to learn and reflect with our trainees and visitors. And this tradition dates all the way back to the 1990s and has really continued on, whether it's outside a real fire outside where John Humphrey, I see him used to cook kettle corn, or sometimes we moved it inside to one of the sitting rooms at IU House. But we've tried to continue this in our virtual format, and it's been a useful forum over the last few months. So anyway, today we are very pleased to have with us a number of folks who are going to delve a little bit more into the educational mission. As many of you know, AMPATH has a motto of leading with care and takes responsibility and holds ourselves accountable to the health of the population as some of our outcomes, but we really find that creates a platform for relevant education and research. And as I said, today we're diving into the education mission that a little more deeply than we have in the past. So over the 31 years of partnership, we've created a number of different residency programs together with our Kenyan colleagues at Moi University, and more recently some fellowship training programs. So now 4 actually fellowship programs are established, and several more sort of on the way or in progress. So today we're going to be focused on two of the fellowship programs in OBGYN or reproductive health, as you'll hear from our panel, these fellowships really fill an important gap, providing access to specialized care for patients in Eldoret and really throughout Western Kenya, and create a pipeline of incredibly talented global health leaders. So obviously, want to acknowledge huge credit really goes to the University of Toronto for leading a lot of these efforts. Nan Oken and Barry Rosen, who unfortunately couldn't be with us today, but they deserve huge credit for their passion and commitment to this. And of course, other IU and other partners have been heavily supportive of this as well. So we're going to start with the Gynecological Oncology Fellowship, the first fellowship created at MTRH or Moi University, and also the first official university Gyn-Onc training program in Sub-Saharan Africa outside of South Africa. So I'm going to turn the program over to Benjamin Eli, who's an obstetrician gynecologist and a graduate of our program in 2019. And he's going to share a little bit about his journey. And if I can just remind everyone to sort of mute their microphones and use the Zoom chat for any comments or questions, then we'll come back to you there. So Dr. Eli.
Yeah, thank you for the opportunity to present about my journey with the fellowship program. I hope my internet holds up. Sometimes it becomes unstable. So my name is Dr. Benjamin Odongo Eli. I am a gynecological oncologist at Moi Teaching and Referral Hospital. I joined the Moi University School of Medicine for a clinical fellowship in gynecological oncology in September 2016 and completed in September 2019. The question that arises is, why did I take 3 years instead of the stipulated 2 years? This was mainly because we experienced industrial action and the strikes by healthcare workers that delayed the administration of exams. However, my training still continued under the Global Mentorship Program under the IGCS. And therefore, I'd call this a blessing in disguise, because I got an opportunity to be exposed to more cases, and I had a lot of caseload that we were recording in our REDCap platform that was tracking the surgical cases that we were performing. I was also privileged to travel to University of Toronto for a period of 6 weeks for rotation in gynecologic pathology, radiation oncology, and also palliative care. I'm just going to give a brief on the background of how this program began. And sadly, by 2008, we only had one gynecologic oncologist in this country, one registered gynecologic oncologist in this country by 2008. And with the rising cancer burden, there was a need to train more people, more specialists to handle the cancer burden. And this fellowship program developed as a collaboration between Kenyan and North American physicians who worked together to develop a gynecologic oncology training program. It began in an interesting way because one gynecologist from Eldoret traveled to Toronto in 2008 for observership. And what happened after that is that the next year, a gynecologic oncologist from University of Toronto traveled to Eldoret. And the mission was to train the local gynecologists to perform excision procedures for precancerous lesions of the cervix. But it was soon realized that there was no structured way of providing care for women with gynecological malignancies. Notably, if you begin a screening program and an excision program, you will find some patients who are amenable to surgical treatment. And it was realized that there was no local capacity to perform surgical treatment, like radical hysterectomies, for those patients who needed it. Notably, with the support from North American universities, there was development of algorithms for treatment of gynecological malignancies, and these were customized to the Kenyan situation. So what happened is that the Society of Gynecologic Oncologists helped develop a module which was in PowerPoint form to train the local gynecologists to treat cervical cancer through surgical means. By this I mean by performing radical hysterectomy. And this was really apprenticeship, kind of, whereby the traditional model of apprenticeship, whereby you see one, you see, you observe, you assist, and then you finally do. So the two Kenyan gynecologists who are working in the clinic, they finally got exposed to a lot of caseload and the support of the North American gynecologists who managed to train them to do radical hysterectomies. With this, there was also the need to develop a more formal gynecologic oncology program to help train and build capacity for local specialists. And out of this, through the direction and leadership from AMPATH and with the support of Reproductive Health Department of Moi University, a clinical curriculum was developed. I mean, a curriculum for clinical fellowship in gynecologic oncology was developed. And as we know that all universities have rules through which this curriculum should go through. This included stakeholder meetings from local gynecologists, even the non-actors in the field of gynecologic oncology. And the curriculum went through all the approval processes, including approval by the Senate. And that's what made this the first gynecologic oncology training program in sub-Saharan Africa, outside South Africa. So, having said that, I'd just like to share a bit of my experience with this program. In that, having gone through the program and having gotten a lot of experience, the administration of Moi University identified that we were equally skilled and capable to handle gynecologic malignancies. And the Department of Reproductive Health was actually expanded, and the Division of Gynecologic Oncology was introduced. And I was appointed as the first chairperson of the Gynecologic Oncology Division at Moi Teaching and Referral Hospital. So in current role, I not only participate in budgeting and preparing the staff complement, but also in mentorship of postgraduate students, undergraduate students, including fellows who are under rotating in our unit. At some point, I was asked to give a bit of my background, and I'm an obstetrician and gynecologist with over 20 years experience in reproductive health. I don't practice obstetrics anymore. the last 5 years since I joined the fellowship program, I've not really practiced obstetrics. And I have an experience of having been the PMQCT lead, prevention of mother-child transmission of HIV and maternal health at US CDC, Centers for Disease Control and Prevention, a post that I held for 5 years before I joined the gynecologic oncology program. I think I'll stop there and take a few questions if any will arise. Thank you very much for the opportunity to present.
Thanks, Dr. Ali. So I think Dr. Mburu Mbarak, you're one of the current fellows, is that right?
Yes, I am.
So maybe you can tell us a little bit about your experience as well.
Okay, good afternoon and good evening to all of you. I'm delighted to be here. My name is Anissa Mburu. I am a second-year GYN Oncology Fellow at Moi University. I did my undergraduate in University of Nairobi, which is in our nation's capital, and my graduate studies followed through in Cyprus and in Moi University. Well, I got involved into the Moi University fraternity back in 2010 when I started my internship. And Adrian, I can share a few slides maybe?
Sure.
Okay, so I'm a visual speaker, so bear with me. So this is a time when I was doing my internship, and some faces maybe are recognizable by some of you. This is when we were all young and sprightly at the time, and one of my other intern fellows went on to proceed with me to do obstetrics and gynecology. And of course, most of you know Dr. Kosgei, who's doing his current fellowship in MFM. And of course, Dr. Miller, who also came, and during my internship and residency, we quite rotated with her. Now, one thing that really struck me into GYN oncology at the time, that's, as Dr. Elias said, that's when the program was being formed. And I was the intern at the time, and Dr. Rosen had just come, and that's the time I first got to meet him. And I had the honor of doing all the skirt work as the intern on call. And my very first night, I was called to resuscitate a patient with advanced cervical cancer. And no one had told me that it's usually futile for most of these patients. And I ended up giving it my all, but patient died. She was 24 years old. She was not HIV positive. This did not sit well with me. I did not understand it. And from there on, it kind of made a switch in my life and in my career. And I really needed to understand how this could happen, what we can do to prevent it. And of course, I took up my residency in my university because to me, I knew there was a gyne oncology fellowship program there, and that's what I targeted. And from there, I finished my residency in March of 2019. And in September 2019, I started my gyne oncology fellowship. So people will always ask, why gyne oncology? This is a very depressing field. And for sure it can be, especially in LMIC, as Dr. Eli has alluded to some of these things. We have quite a big challenge, especially when trying to get some drugs that we would want to use, some of the new modalities that are available. There's some surgeries that we'd want to perform that we're not able to. And we are very limited in this process. But that has made us quite innovative. And with time, it has even given us more determination to help this patient. So this is a patient of mine that I want to share her story with, and through it, it will give you an idea of how it is on the ground in the gyne oncology fellowship. So I met her in my residency when she was just a 24-year-old, and she had been sent in from a different facility. They had done a suboptimal surgery for what was an ovarian malignancy. So we had to reoperate on her. And of course, this causes a lot of delays. And it's one of the main challenges we face as GYN, and in fact, literally the only GYN center in Eldoret, where we serve a catchment area of about 20 million people. So we have so many patients coming in, they've been suboptimally managed in different facilities, and we literally have to start from the beginning. So we have to reoperate them, and this causes, of course, a lot of delays in initiating the appropriate therapy, and it also costs a lot, costs money to the patient, which most of the time is not in good supply, and as well as causing a lot of morbidities. Well, for this particular patient, we ended up, as we operated on her, it took us about 3 weeks before we got our pathology report. Now, again, another challenge that we face, because at the time we only had 3 pathologists in MTRH, about 3, maybe 4. And as I say, they're serving a catchment area of about 20 million. So we can't have a very high turnover in terms of our specimens. So by the time we get the pathology report, it's vague and very inconclusive. We do not have a subspecialist pathologist who's trained in gynae-oncological pathology. So some of our reports will always end up being a bit vague and inconclusive. But nevertheless, for this patient, we started on chemotherapy. And as she was doing her chemotherapy, she had a lot of delays. Number one, at some point, her health insurance ran out. And of course, it caused a bit of delay before she was able to get it back and continue on with the medicine. And then she had some grade 3 hematological toxicities. Blood in our setup is very difficult to get. So by the time we're able to transfuse her, get her back to do get rid of her bone marrow suppression, it also delayed the chemotherapy. But at least she finished her chemotherapy, and 6 months when she was undergoing her follow-up, she comes to the clinic again. And one thing we need to mention about our clinic is we only get to have 1 clinic once a week. And in this time, we can see up to about 50 patients. That's a very high number. Up until last year, we'd only be about 2 fellows at a time. So imagine you have these patients. Some of them, you're going to tell them that they have cancer. Others, you're telling them that they're not going to make it. The chemotherapy has failed, or there's no other options for them. And you still have to, you have about 50 patients waiting. So we've not always been able to give out the care that we would want to, have the time to talk to our patients. And we're still trying to address this. We've got more fellows who have joined in, but it's something that has really been quite challenging for us. But for our patient here, she's come back, she has 1 ovary, and luckily she was pregnant, something that she really, really wanted. And she was happy about it. We linked her up with an obstetrician. And unfortunately, at about the 3rd trimester, we noticed that she was having a mass in her other ovary. But she went on to deliver a healthy baby, and her insurance had run out again. So it took about 4 months before she was able to get it back, and we were able to scan her and operate on her again. And for sure, the cancer had recurred. But now we had to remove her uterus and her remaining ovary. So now we have a 27-year-old who has no uterus, has no ovaries. And we told her now we have to deal with effects of menopause. And of course, that is something very difficult in our setup because we don't always have all these hormones available to us. But her response, as long as she's alive to take care of her baby, he can handle whatever comes along. And to me, this is one of the most gratifying things in being in oncology, having to meet such brave women who are able to take on the challenges and face them on ahead. So now, with this case has just highlighted some of the challenges we've faced. And I want to say that the best thing about it is that we've not been alone in our journey. And we've had excellent mentorship from our founding fathers, Dr. Itsura, Dr. Omenge, and Dr. Tonui. They've always been there to guide us. And of course, we've had immense help from our international mentors, Dr. Rosen and Dr. Covens. We literally want to put them on a pedestal because, especially with the COVID pandemic, they couldn't travel to us, we couldn't do our exchange program. So from April of last year, we started doing our COVID sessions, we call them. So every twice a week on Tuesdays and Fridays, we'd have sessions with Dr. Rosen, Dr. Covens, and we would discuss our difficult cases, discuss topics on oncology. And through that, we were able to maintain our learning. So despite COVID, we still continued learning. We were able to get our new fellows to join, and we were able to even compare management in a low resource setting like ours and a high resource setting like theirs. And through this, one thing about this fellowship that has been quite uplifting also is, if I can make a reference to my Tolkien fans, fellow fans, the fellowship is never ending. We have those who have cleared, who are practicing in different areas in Kenya. But during our weekly tumor boards, they'll always join in. We discuss our cases, we talk about the challenges they're facing, and they also encourage us as the current fellows to continue on. So this fellowship of ours is literally binding for life, so to speak. So it has really, really helped our situation. Another perk of being an gyne-oncology fellow in Moi University is that we have gotten enrolled in the IGCS fellowship program. This is the International Gynecological Cancer Society. And through this, we meet with several other fellows in different LMICs like Mozambique, Uganda, Ethiopia, Vietnam, and even Jamaica. And we get to talk to them, discuss cases, discuss the challenges they're facing. And sometimes when we have similar challenges, we'll be like, you know what, they handle this in a certain way, and we can actually apply this. And of course, once we finish our 2-year fellowship program, both in Moi University and IGCS, we get to be accredited internationally. Of course, we probably won't practice in different countries, but at least we have that international, can I say, education, so to speak. Now, to finish, basically, with all these challenges that we face, we find that we still get a lot of patients. And right now, our presence is being recognized in all of Kenya and sometimes even Uganda. And we're having more patients coming in. Yes, we are saving a few, and we are able to help those who we cannot save at least have a better quality of life in the end. And that's why it's not all depressing and dreary for us, because as much as we know sometimes you're facing a losing battle, for this patient, that relative, we are able to make a difference in their life. And to me and to anyone who would be interested in joining an oncology field, I'll always say that is a gift that we cannot take lightly. And so if I may share a quote with from one of my mentors, it's something that has really helped in my life and in my career. It goes that, I shall be telling this with a sigh. Somewhere, ages and ages hence, 2 roads did diverge in a wood, and I took the one less traveled by, and that has made all the difference. This is by Robert Frost in 1920, and I hope you can, some of you can I say, recognize with this particular poem and maybe help you in your life. AMPATH has really helped me in my life in terms of getting some grants for my studies, like the NIHU 54 grant and the preceptorship grant. So with this kind of forum, it's really great to show that with this oncology program, with all the things that are happening, there's a lot of lives that are being changed. So thank you again for having me. I hope I've not talked too much. All right, thank you very much.
Anissa and Ben, thank you so much. I think, all of us who have spent significant amount of time, unfortunately, know and have been touched by someone with cervical cancer. And I think your story and your description and your obvious passion is actually very moving. And just shows how all of us working together can overcome all the barriers and the challenges that you've laid out. It's really just inspiring. So thank you very much for sharing that story. Tough act to follow, Nan. We're going to switch over now to the MFM Fellowship, which was created a little bit more recently, but pleased to introduce Dr. Nan Oken, who's a maternal fetal medicine specialist at Mount Sinai Hospital, an associate professor of OB/GYN at the University of Toronto, and she will introduce her fellows as well. So, Nan, take it away.
Perfect. So when something is working so well, you should never reinvent it. You should just plagiarize it and adapt it. And that is exactly what we did in maternal fetal medicine. So I had the honor of being there in 2014 when the 2 first gynae oncology fellowship people graduated. And I was the official photographer. So as I was taking pictures and listening to their inspiring speeches and listening to how proud Barry and the fellows were to get the first cohort through, I thought this is something we should do in maternal fetal medicine. Certainly if there are people having morbidity and mortality from gyne-oncology sources, the pregnant population for sure has high-risk people, both from maternal conditions and fetal conditions. So Dr. Nyongesa and I were sitting at the same table at that banquet, and we said, we should do this. And he said, I'm not sure you have the stamina. And I basically just took that curriculum, and with Dr. Mamlin, who's on the call, I can see his words burning in my mind. Don't forget to start. You just limp along one day at a time. And we took that curriculum and basically adapted all the same principles of MOI, the same sort of process of the objectives, the learning styles, the model of learning, put it through all the layers. And that took 4 years. And then we were able to recruit our first 2 amazing fellows who are both on the call. And if I would say one of the conditions, one of the principles that I've learned is that to start with, it's really nice to get consultants in the system, and consultants that really have skin in the game, that really whose careers will benefit and who will benefit others from their skills. So I'm going to leave it there because I think that Drs. Bett and Pallavi are both on and probably can talk more authentically about their experience, but I'm happy to answer questions.
Great, thanks, Nan. I'm not sure who's going first.
Hi.
Hi, Bet.
Hi, Nan.
Hi, Bet.
If I try to switch into video, I will lose you guys. So allow me to just proceed and just make a comment about MFM. Hopefully my net will not interrupt. But then my name is Beth Kipchumba Chamalan. I'm one of the first MFM fellows here from Kenya, together with my colleague, Dr. Pallavi, whom I believe she's also on the call. Today, Thursday, I was running the MFM clinic, and Sharon, one of our clients, who is 6 weeks postpartum, passed by our clinic to say thank you. Sharon is a lady whom we stayed with in our unit for more than 2 months. She was admitted after about 27 weeks with severe mitral stenosis in pregnancy with a valve area of 0.8 centimeters square. She was admitted to CCU, that's the cardiac unit, about 4 times. And the rest of the time she spent in our antenatal ward. She was quite sick. Long story short, she's 6 weeks postpartum. Not because of MFM, but because of what MFM has made us think. There was multidisciplinary team approach to our care. And still, of course, on care and linked to cardiac units. But mom and baby are quite okay and stable. Yesterday, we attempted to do an amniocentesis for a lady in our unit who has severe polyhydramnios and quite unwell. We did not succeed, but we are happy that we are trying and attempting to improve care for our mothers. This is courtesy of the maternal-fetal medicine unit that Nan and the team that she mentioned established. And I'm personally proud to be in that team that has opened my eyes into maternal and fetal well-being. Here, mother and baby is a priority. For the last now almost 2 years that we've been in this program, we are growing, we are thinking outside the box. We are hoping for the best for our mothers and babies. We now have another fellow, Dr. Koske, who is in year 1 and doing quite okay. And we are hoping to recruit 2 new fellows in the month of April first week. The 2 of them will be one from Nairobi, for those who know Kenya, and one from the counties. So the program is growing. Personally, I train in Moi University for undergraduates and postgraduates, and now this fellowship in partnership with the University of Toronto, courtesy of Nan, who is basically our mentor. So I breathe, think, grow, and pump blood of Moi University. If I'm today asked, is MFM making a difference for mothers and their, babies here? I'll say a big yes. How is this changing care? One of the things that is us done is one, our presence in the unit, now with focus on high risk obstetrics. So we are seeing, these clients who need our service and linking them with the other disciplines, following them up and being there during their care plans. I'll mention about one of the leading morbidities in our unit, which is hypertensive disease in pregnancy, specifically pre-eclampsia. Over the last couple of 2 years now, almost, we've seen the approach to management of pre-eclampsia, for example, change with a follow-up and care plan, especially with use of with fetal surveillance, making use of one of the best ultrasound machines that we have in our unit, and actually the best in the hospital, to just do fetal surveillance. Once we have come in contact with these clients, this has really made a difference in terms of care, and that just pre-eclampsia presenting to us in pregnancy is not just about delivery, but making use of this machine that we have to see how we can, at least prolong in utero life for these babies that we know in our region as a low-income country. The uterus for a baby is a better place than our NICU services. We have a newborn unit. We have a team there. We have now a neonatologist that definitely, when decision comes to deliver these mothers, they take care from there. For those who've been here in our unit, we always talk about our age of viability is 28 weeks. Last week, when we had a meeting with Koskei Pallavi and other members, we've come to realize that ideally there is no baby who should be condemned to die just because they are less than 28 weeks. We strongly believe that babies should not just be, categorized as this is not viable because you are just below 28 weeks. We've been privileged to see and participate in the Toronto rounds on Tuesdays, the fetal rounds, and we've seen how aggressive multidisciplinary team approach come on board just to make a difference for babies remote from term. Then we ask ourselves here, what can we do to make a difference? And this is now where we aggressively pursue multidisciplinary team approach, trying to make a difference for each newborn that comes to us. Another example I mentioned when I just began, I talked about this client who passed by our clinic today, just to say thank you, is the burden of cardiac disease in pregnancy, especially the sequelae of rheumatic disease and seeing the complications thereafter. We have quite a number now of women who present to us in pregnancy or during pregnancy with cardiac disease, specifically rheumatic disease, which is quite prevalent as a result of complications of rheumatic fever earlier on in life. These women come to us in pregnancy quite sick most of the time. And we are always torn between, a rock and a hard place. What can we do to make a difference for the mother and make a difference for the baby? One of the things that this training is also helping us appreciate a lot is what I've mentioned as the multidisciplinary team. We have now a cardiology fellowship that is running at Moi University. And for sure, if there is one collaboration that I'm proud of, is the collaboration between our units in obstetrics MFM and the cardiology unit when it comes to pregnant women with cardiac disease in pregnancy. If all disciplines could run this way, we would have huge impact in terms of care in a low resource setup. For the cardiology team, they are always there for our patients. We discuss, we make plans together. They always create time and space for mothers in their unit. For those who are quite sick, they admit. We do joint discussions and plan when and how to deliver. Before this fellowship, the story was different. But going forward with this kind of approach as a multidisciplinary team, we look forward to better maternal and fetal outcomes for our mothers. We now have a clinic that was not there before this program began, that we are seeing, we call MFM clinic, that runs every Thursday, that we are following up our clients. We've recruited quite a number for those medical conditions in pregnancy that are either referred to us or we see in our routine antenatal clinic. So this is a clinic now that is running, and it's being, run by the MFM, myself and Dr. Pallavi and Koske. We recruit them and follow them during pregnancy and plan their delivery. And for sure, this is the way to go. We are now getting referrals from other facilities and counties having heard about MFM. We are getting phone consultations just because of this program. What can we do? Can we send a client to you? And for sure, we are growing. Definitely, Rome was not built in a day. Dr. Anissa Mburu talked of a road less traveled, but having had our partners travel the untraveled or the uncharted roads, I believe, following them and them holding their hands and guiding us, baby steps, we will walk and we will run. Definitely we have we still have some milestones to make, two major ones that I'll mention. Having seen the practice that in Toronto, as we joined us, the issue of the genetic studies and analysis that we don't offer here. And if indeed it happens and outsourced there, it's quite expensive. As this makes a difference, especially for diagnosis of fetal conditions and syndromes that can influence the kind of care these women will receive during pregnancy and even postpartum in planning their future pregnancies. The other one, of course, is on fetal therapy. Seeing what happens in Toronto during the fetal rounds, definitely it's amazing stuff. That it's my dream that as this program grows, no matter how long it will take, the Kenyan women who are pregnant with fetuses that need fetal interventions, with women with medical cardiac, medical disorders in pregnancy that need care to improve their pregnancy outcomes and their well-being. I strongly believe that Kenyan women do deserve such kind of, approach to care. Kenyan fetuses which that need fetal interventions will one day, courtesy of this MFM program, enjoy. I strongly believe that all the programs begin somewhere with mentorship, with dedicated team, with passion. Nothing is impossible where there is a will. I will probably stop there to allow my colleague, Dr. Pallavi, maybe to make a comment and maybe, get some questions. I definitely will not, without saying, without the support of, Nan and the team that she organizes, virtually or physically before COVID, I don't think we would be where we are. As I speak, at 9 o'clock, we have a lecture virtually on obstetric analgesia and anesthesia, organized by, NAN, and this is how things are going. So even with COVID, we are holding on, we are learning, we are growing, and we'll keep going and looking forward. Thank you.
Thanks so much, Bet. Dr. Pallavi?
Good evening, everyone. Sorry, I had not prepared for this talk, but I just echo what Dr. Bet said. This 1.5 years have been a very great journey, and I really congratulate the leadership who have been guiding us like tirelessly, not even one single day, not even whenever we need their help, they're always there. And I think that has kept us motivated. And we have reached where we are, and we really hope that we'll grow as we become a proper team in Moi Teaching and Referral Hospital, and one day we'll reach very great heights. I truly believe that. And yeah, I just thank everyone to help us in coming out well in this program. And yeah, I think that's what I want to say. We are really thankful for the leadership, and I'm sure we'll be seeing more of our junior fellows who will be joining, and we'll go great heights. Thank you.
Thank you so much. I think it's interesting to hear all of you reflect on the sort of the multidisciplinary nature of these things, and how these, once you get to this level, it really requires sort of a team effort. And we had a person with a gynecological oncology problem who gets pregnant, who probably needs MFM, and then someone who really needs cardiology. And you previewed our one of our future highlight sessions, probably to highlight the cardiology fellowship and just the remarkable work that Duke has done in bringing up that effort, and just demonstrating how it all works together. And I can't help but reflect also just that if you think back even 10 it's actually over 10 years now to the efforts of Jim Lemons and others who really championed the building of the Riley Mother Baby Hospital, and that infrastructure that's just been so critical to providing the care and the development of these educational programs as well. I do just want to add also that that while we focused on these educational programs that are obviously a high level tertiary kind of training programs, that they really are complemented by a lot of AMPATH's work in the community as well. So we're, cervical cancer in particular is obviously a vaccine preventable disease that can be, cured if screened and determined, discovered early. And so we've done a lot of work with the oncology program to get out in the community and empower nurses to do cervical cancer screening and find early stage disease and try to prevent the need for the late stage complications and the hysterectomies as well. And similarly on the the obstetric side, empowering community groups and lower level facilities in the health system to triage appropriately where there's need for a higher level of care. So I'll pause there and see. It looks like we have a little bit of time for discussion or questions. If anyone else wants to add anything, feel free to jump in. Just unmute yourselves.
Can I just say that COVID has had a very strange effect on this, in as much as it's been devastating to not be able to visit. At least for MFM, it's opened up a ton of opportunities. So not only do the fellows join with us in our weekly, essentially they're with us at least 3 times a week in our rounds. And the other thing is that I think this must be the same in other specialties, but most of the major leading organizations and guideline setters have international interest groups. And so the registration fees have dropped. And so our fellows have been able to attend international meetings. So right away, even during their fellowship, they get virtually connected with the gurus of the subspecialty and get to see how things are developing alongside those of us that are experienced. So it's had some weirdly positive and some negative effects for sure.
We'll take those silver linings.
We'll keep those, yes, we'll keep those positives for after. Yeah.
So I know there's been some chats around the developments of other fellowship programs, and there were some questions I think that came in ahead of time around, obviously we've developed a model here of developing these higher training programs at Moy University, and I think, certainly there's interest and need for additional specialties within reproductive health and within other areas as well. So there was one question, I don't know what's the capacity for social workers or counselors to be able to be accessible for these women. I don't know if any of you can comment on that.
Well, this is which women? Is it the gynecological women with reproductive tract cancers or those ones with?
I think it could be both, Ellie. I don't know I'm not sure which one specifically it was targeted at, but I think the importance of addressing mental health issues in patients who are suffering in other ways and is obviously critical across the board. So if you have something to add about in your context, that'd be great.
Yeah. First, thank you again for the opportunity. I must admit that we've had a bit of a challenge, especially with those insurance have run out and those who are in hospital for long. Others have been sort of abandoned by their relatives, so they end up staying long with us. I may give examples of those with advanced cervical cancer, whereby we may need help to trace their origins and where they come from. And the social workers have lent a hand in trying to help us in this particular aspect and sphere. But I must also admit that this has been a challenge because probably our training initially was the usual exposure to the scope of social work had not expanded to include patients with gynecological malignancies. And I think it's something that we need to explore to rope in the scope to cover our patients with gynecological malignancies. Now that I'm still on the floor, that's one thing I wanted to report on. Initially, when we first began the fellowship, we used to refer our patients who required radiation to Nairobi and Uganda across the border. But currently, we now have capacity to perform radiation, especially for those with advanced cervical cancer. And sort of our fellowship is now actually complete, that we can now offer the whole spectrum of care for our women right within our unit.
Ellie, thank you very much for highlighting that. I know it's been kind of leaked out in the news, although the formal announcement hasn't been made by MTRH, but I think obviously been waiting a long, long time for radiotherapy services at MTRH, and we're now there, which is very, very exciting and obviously huge impact clinically for your patients as well as many others. So we are very, very excited about that. And the fact that that could continue despite COVID, I think should give us all hope.
I don't know if I can speak into Adrian, and I maybe I didn't hear, it's Julie Thorne. I'm not sure if I show up as Julie or Joe, but I think that the Gyne Oncology Group has been working with the palliative care service, and it's been highlighted and brought up in the past that there's probably a whole scope for palliative care and counseling involvement across the MFM and neonatology spectrum. And again, I think like some preliminary work was being done to sort of explore that either through a QI type project or that sort of thing, but certainly an area where there's room to grow. And I think someone else in the chat has mentioned that too.
Yeah, thanks, Julie and Colleen. Thanks for the chat.
Hey, Adrian, this is Jim Lemons.
Hey, Jim.
I was just going to also add, along with Julie's comments, that the chaplaincy program is also available, although with a complex relationship with Moy and MTRH, Arrawasa has kind of put a hold on the clinical bedside training for our chaplains. But we are looking at putting together actively right now with the CTSI Reciprocal Innovation Grants, a program where one of our young PhD faculty has kind of specialized in teaching spirituality to healthcare providers to then be able to lift up and affirm the spirituality journeys of patients and families, etc. And we're looking to put together that grant and to hopefully, if accepted, begin this year, if not next year, hopefully, to develop a curriculum to actually engage our chaplaincy program there to help train, healthcare providers at every level, student nurses, doctors, et cetera, social work, whoever would be appropriate, to see if that could help also, address the capacity needs in this really, really important area. So thanks.
Thank you. And sounds
Hi.
great.
Can I just ask a question?
Please,
We've
Rose.
talked about treatment. We have to make a diagnosis before we treat. And I wanted to know if your imaging colleagues are familiar with the IOTA or ADNEXA program where you actually give people a categorization, and it's kind of been tried and tested, certainly through the whole of Europe. ADNEXA is the European program, and then there's IOTA or ORAS, which is kind of more America-based. There's a combination, and it just puts you into certain categories. I mean, it's all very well to say, well, we have to look after, but you have to make the diagnosis first. So it's a question that I'm asking because I want to know what you guys are using in Kenya, and is someone looking at that?
Any of those in Kenya know or can respond to that? I'm not sure, or if one of the former team leaders, Julie or Caitlin.
I mean, Ellie or Anissa, if you're on the phone, you can kind of speak to how you work with your imaging colleagues for making your diagnosis. Sometimes I'd say that presentations of cancer are quite far advanced. And Rose, you know this, but I definitely think from a gynecologic imaging standpoint, particularly around the use of transvaginal ultrasound, is another area that that we can certainly see our imaging capability in OBGYN grow. And so I think it remains on the list of areas that we hope to see expanded.
Now, I recognize that it's sadly presents advanced, as the lovely young lady fellow showed her the case and the example. Having said that, first of all, it's very, very, very important to separate benign from malignant. And in actual fact, although we're now talking specifically to people who have malignancies, it's also very important to be able to elucidate that diagnosis. And perhaps we should encourage Nan, somebody from U of T, to speak to that in terms of just for yourselves. So you're educated enough to say to your oncology, to your imaging colleagues, well, let's at least categorize them correctly. It's like seeing the fetal medicine issues. I know that you have a wonderful machine there, and with 3D capability, I've been told. And yes, I mean, I don't think we can run before we walk, but I think that I remember many years back going with a vaginal probe as a gift, and they looked at me like I was from Mars. But with time, people do accept it, and if it's for their life, and they've become accustomed to that. So pushing the right approach, especially in a teaching center, I would say is a good start from the grounds up, because it then teaches the residents and the people who are the medical people, the residents and the fellows, to do it in the correct fashion. And then we can always go back in that respect. I mean, as Nan knows, I'm a little bit fanatical about imaging and doing it properly. But I just feel that we pay so much attention at U of T and in Canada and in America. And if we're working globally with Kenya, we should at least impart that knowledge to you guys.
We'll have to welcome you back to Kenya, Rose.
Don't joke, because I'll probably come.
No, I'm serious.
As soon as COVID is sort of on the tail thing, I would pay you a visit and try and teach you. But I think, you know, we have the big advantage of Zoom now, and we can teach remote. And I think that that's, you know, it's an important tool that we should be able to try and use.
I'm really sorry. I have to jump off so I can get ready for our 9.
Okay.
Thank you, everybody. I make my heart swell.
Yeah, absolutely. Thank you, Nan. And really thank you to all of our panels for sharing inspiring stories and the incredible impact of your work on women and families in Kenya. And thank you all for tuning in. All of this work, as you all know, relies on support of the people like you and donations that allow AMPAS work to continue and to serve women and families. So if you're interested in supporting some of the initiatives we talked about today, please feel free to reach out to us. And I did want to put in a plug for next month. Our next month's Fireside Chat will actually be in conjunction with the Gateway office, the Global Gateway office at Indiana University. And it's actually on a similar theme. It's access to quality maternal and child health care. And Laura Rule will be moderating that. It'll include highlighting Deb Litzelman's work here domestically, as well as some of the Chama's work in Kenya, and also some work in Mexico. That's part of our Indiana University's relationship with the Mexico Gateway. So we're very excited about that. That's March 17th at 9:30 a.m. So the timing will be a little bit different, Eastern time, 9:30 Eastern time. So we hope to see you all there. Thanks again for joining in.